I think one of the barriers to good end-of-life care is that ICU clinicians need to put down their stethoscopes, and they need to begin to learn skills in how to actually be with a dying person.
End-of-life care is a skill. We're not born with skills. We develop skills.
One of the things that I think is very important in teaching physicians how to communicate better with family members about end-of-life care in the ICU is really to teach them to treat it like a procedure. Teach them to think about it in the same way they think about putting in a pulmonary artery catheter or putting in an arterial line.
I'm pleased to say that in many, many cases, the bereaved families in our ICU are grateful for care that we provided even when the patient did not survive.
One would think, given how frequently people die in the intensive care unit, that talking with patients and families about death would come easily for the critical care clinician. The irony, unfortunately, is that just because we see death all the time, we are not necessarily comfortable with it. Hello, I'm Dr. Mitchell Levy, Associate Professor of Medicine at Brown University School of Medicine and Chair of the Robert Wood Johnson Critical Care End-of-Life Work Group. As clinicians, we aren't trained to feel comfortable with death. Combine that discomfort with our lack of training and good communication skills, and you have the makings of difficult times for dying patients and their loved ones in the ICU. Can we do better? Of course we can. The first step is for us as caregivers to recognize and accept that we do have a problem. Family dissatisfaction with the kind of care received during the death of a loved one while in the ICU has now been reported in many published studies. As a community of caregivers, we must now approach end-of-life care as we would any therapy offered to our patients, one which requires trained skills and continuing education to further maintain and enhance these skills. Through a generous grant from Orthobiotech and in association with the Society of Critical Care Medicine, this video has been developed as a small step toward addressing the challenge of providing the best end-of-life care possible in the ICU for our patients and their families. In the next 25 minutes, prominent experts on end-of-life issues candidly share their views on the major barriers to quality care. They discuss strategies for improving caregiver skills in the ICU and describe some models for optimal end-of-life care. Let's begin by getting an overview of the problem.
America is aging, and with that, the prospect of dying and dying a comfortable death is closer to us, both professionally and personally.
Well, I think there's been more and more evidence that patients and their families want better end-of-life care, probably because they're more aware that it can be better than it is.
And I think the public is becoming much more aware of their options, and they're demanding a different standard of care. And as professionals, I think we have to listen to those concerns and to respond to them appropriately.
If you ask the question whether most clinicians feel that end-of-life care for patients dying in the ICU could be improved, the answer is it depends on what kind of clinician. In my experience, most nurses would agree with that statement. Most nurses that I work with in ICUs feel that we could provide much better quality of care in the ICU.
I think most of the reliable criticism of the ICUs has come from physicians who spend a fair amount of time in the ICU and as a result are aware, again, of its strengths and shortcomings.
Most clinicians would say that end-of-life care in the intensive care unit could be better. Our symptom control could be better, our communication skills could be better with patients or more commonly with family members. Our listening skills could also be better, and research has shown that over the last decade.
There is a challenge to all of us to begin to really look at how we provide care. What are the systems of care that are necessary to really provide humane, compassionate, and good clinical care of all dying people.
Suffering at the end of life, unfortunately, is common. It is not necessary in many cases, but I believe that it is still far more common than it should be, and that is of great concern to everybody involved in this process, to the patients and their families, and to the physicians.
On the one hand, there are some very obvious barriers in the intensive care unit itself. It's a cold environment, there's a lot of light, a lot of noise, there's very little privacy, there's a lot of busyness, and there's not enough attention to the comfort needs of patients and their families for that matter.
It's fast-paced, it's dynamic, there are multiple caregivers there, and it's not so conducive to quiet, careful, extensive discussion about emotionally sensitive issues like death and dying.
A primary barrier is really knowing what it is that the patients experience. And there are many good reasons why that is a barrier. Most of the patients in this situation are not able to communicate with us. They're nonverbal, they're uncommunicative, so we really don't know what the experience is like for them.
Patients who are seriously ill cannot talk to the caregivers. We cannot talk to them directly. We're often going through family members, next of kin, surrogates, alternate decision makers, and that can be very difficult because we need to try to understand what patients would want if they could speak for themselves, and that often gets mixed up in what other people would want for that patient.
There have been a number of studies that have asked patients what kind of care they would want in various different situations where they might be critically ill, and then asked their physicians what kind of care they think the patients want. And these studies have shown that physicians are not very good at predicting what patients say they want.
I think based on the findings of the support study, it's very clear that clinicians are in many ways unaware of what patients and families want. I think the biggest reason for that is we just don't ask. We assume that we know what patients and families want.
I think probably an even greater problem is that many patients don't know what they want. Or if they do know what they want, they know what they want at one moment in time and have a difficult time really thinking about what they would want in other kinds of circumstances.
Patients are variable in the level of care that they desire, and the families of patients have different views about what care they desire for their loved ones. I also think that physicians vary in their level of understanding about what care preferences patients and their families actually have.
And one of the ways we could try to get on the same page is just have better communications about the general direction of care and also the specifics, the specific technologies that we might utilize, and be sure that everybody understands what the technologies or devices or drugs can do and what they can't do.
The thing that we really need to find ways to improve is the way that we talk to patients and their families. And we need to do that in two ways. One is we need to build into the structure of our ICU care systems that allow us to have better quality communication, that allow us that facilitate, for example, family conferences. And we also need to teach clinicians, both nurses and physicians, tools and skills that allow them to communicate better with both patients and their families.
I think one of the barriers to good end-of-life care is that ICU clinicians need to put down their stethoscopes, and they need to begin to learn skills in how to actually be with a dying person. Well, what does that mean? Well, being with a dying person means that you need to show up fully in your professional role, to be willing to take your hand off the doorknob, to sit down, to look that person in the eye, to take their hand, to touch them, and to really listen to what they're saying. If we can do that, then the rest of it is easy.
Communication is most commonly identified in recent literature as the single most important factor for patients and their families during end-of-life care. This communication barrier is composed of multiple factors, ranging from the physical environment of the ICU to the misunderstandings and conflicts between physicians, patients, and families. So what is the starting point of this end-of-life dialogue? Quite simply, it begins with a caregiver being willing to have the conversation. While this may seem straightforward, in reality, it turns out to be one of the most difficult tasks expected of a critical care physician. Unfortunately, as already mentioned, most physicians receive precious little training in communication skills. Thus, when faced with the prospect of a difficult discussion involving a transition from a curative to a palliative approach, many clinicians become anxious.
Discussion about our preferences for end-of-life care, I believe, should begin when we're healthy. They should be part of discussions within a family so that the family understands what our preferences and our concerns are.
If you survey outpatients who are relatively healthy, The vast majority of them say that they do want to have conversations with their physician about the kind of care they'd want at the end of life. And in fact, they say the earlier the better.
When a person finds himself or herself in an intensive care unit, there's always a balance about discussing end-of-life care issues and promoting hope for the family members. But it's essential that these discussions take place. The discussions aren't easy. It's difficult to break bad news to family members. But if we do provide these discussions, if we're proactive in our communication with family members about what we believe the patient's prognosis is, then this helps to prepare the family members so that they're not caught up short, so that they're clear, and it gives time for some resolution within a family.
We do not have the power to extinguish hope on the part of patients or families. Patients and families are going to continue to be hopeful regardless of what we tell them. And by being able to put the issue out on the table, we have now diminished the isolation around that particular issue. Patients and families are thinking about those kinds of questions. And it is, in fact, a professional responsibility to be able to put that issue out for conversation. When we don't do that, we are really denying that patient and family and ourselves the opportunity to address it and to work through the issues that come up around end-of-life care.
This issue has been described as the elephant in the room, and the elephant is there and needs to be directly addressed. And often patients and their families are much more anxious and much more upset when the elephant is not addressed, and when there's only silence, when there are many, many questions and many, many issues to be discussed.
I think clinicians have a hard time talking with patients and families about end-of-life care, DNR orders, for a couple of reasons. One is that it's very difficult to talk about death and dying. We, as a society, have a lot of issues about denial of death. As clinicians, it's hard for us oftentimes to admit that we can't save a patient's life. Oftentimes we feel a little unsure about ourselves and our own skills. You know, am I missing something? If I was a better doctor, would we not be talking about end-of-life care, but instead be talking about discharge planning?
We want to be absolutely sure that we are right when we say we don't think you're going to get better. And so we resist it. We also resist it because it's a difficult conversation to have. And by doing that, we, I think, undermine our potential for being able to make good end-of-life care plans with patients and families.
Physicians also feel guilty when a patient is dying. Physicians often see this as a professional failure rather than the inevitable consequence of the illness. These are all reasons why physicians avoid these conversations. And these conversations take time. They simply take time. And time is very precious. There are competing clinical demands, there are competing academic demands, and so it is hard to get the time to have these conversations, but it's absolutely essential.
Although we have benefited greatly as a result of advances in critical care technology, these advances have presented us with considerable ethical challenges. These new life-extending technologies and therapies have generated a growing number of medical legal questions regarding end-of-life care. Unfortunately, these questions are often used by clinicians as a means for not initiating end-of-life discussions. As clinicians, we must be willing to look at ourselves and honestly examine our motives for avoiding difficult end-of-life discussions.
I believe that medical legal issues should really not come up very often in directing the kind of care we provide to patients at the end of life. The most important way to avoid medical legal problems is by communicating with patients and families up front. There have been a number of studies that have shown that the best way to avoid being sued is to have good quality communication with patients and their families. And I think, in my experience, I think that physicians think about medical legal issues more often than they really need to. For the most part, I think the most important issue is providing good quality care.
I believe that physicians who practice good medicine, medicine that is consistent with professional standards, medicine that is compassionate, conscientious, and medicine that they could share with their colleagues and get feedback from and approval from should be at no risk and should not have to worry about medical legal concerns.
If we approach our practice of promoting pain relief by offering pain medications, and that is and comfort is our intended goal, then it is very clear that we are morally and ethically and legally providing appropriate care.
What I get concerned about is healthcare professionals who want to immediately move to it's illegal as the reason for not providing appropriate end-of-life care. And I think that when we do that, we have not fulfilled our obligation to the patient or the family or to our profession by taking that tact, which often leads us to say, well, nothing else I can do, it's against the law, and rarely does that feel like a satisfactory answer to those difficult questions.
I think it's important to be familiar with all of the standards that are locally applicable, the statutes, the case law, and whatever administrative and hospital regulations apply, and also to document carefully why treatment is being given. And provided that this is done, I think that physicians can give excellent end-of-life care without great concern about medical legal concerns.
As we try to interpret the legal framework, be clear about where you're getting advice, whose interests are being served by that advice, and how do we incorporate that information into a plan of care that honors both our obligations to patient and family and our professional obligations on behalf of all the patients and families that we serve.
If in the long run we are to improve end-of-life care, we must begin by candidly assessing our own current attitudes about death. If as caregivers we are uncomfortable with the prospect of death and loss, we cannot expect to be able to offer a nurturing, reassuring presence to our patients. Only by becoming comfortable with the dying process can we expect to help our patients and their families accept this inevitable transition. Fortunately, there are specific strategies which we can adopt for optimizing end-of-life care.
The advice that I would give to patients and families, and particularly to families with whom I deal with most of the time, when they become frustrated by the intensive care unit, is to have them understand what the intensive care unit tries to do. By its very name, intensive, it implies that the care is going to be intensive. It's going to be very, very aggressive. And the intensive care unit is really should be thought of by families and patients and by practitioners as a therapeutic trial. It's a place where you go to see if you can get better. And in the process of trying to get patients better, we're going to do a lot of things that are potentially very invasive, even potentially hurtful, although we can certainly give drugs to try to keep the suffering to a minimum. At the same time, we are often going to reach a point when the therapeutic trial has failed and the transition from aggressive care to more palliative care has to be considered.
Healthcare providers should take a proactive approach to the attention and the care that is necessary to be given to family members. One way of doing that is, like we do diagnoses of patient conditions, I think we could do a family diagnosis proactively, assess the family, assess their needs, recognize the stresses that exist, look at the patterns of communication among family members, and anticipate where we may be getting into conflict with a family member.
It's not uncommon in the ICU to be involved with families where, for example, sons and daughters would come from different parts of the country, or in some cases the world, to see their parents who are dying and have not seen them for many, many years. And coming together at a time like that is very stressful and also tends to open old wounds that may exist in the family.
I think many healthcare professionals have this idea that when a problem like that presents, we ought to be able to fix it. Unfortunately, when a family presents, they come with their years of experience and the dynamics that have developed there. It's very unlikely that we're going to be able to change that in one short interaction. So often the best we can do is to try to create a place where we can make sure that all the voices are heard and that we can be respectful of different perspectives, that we can offer a process for how decisions will be made.
Usually listening and taking the time to have the communication will resolve many of the conflicts. Most of the time, what people want is information about their loved ones in terms that they can understand, and a sense that the physicians are committed to providing the information and dealing with them and their loved one in a compassionate way.
And to think about the skills that you need to do that, to prepare for it beforehand, to think about the information that you need to have before going in and talking to a patient or family member, to think about the setting in which you're going to do it, make sure it's a quiet and private setting, try to minimize interruptions, and to make a plan for the things that you want to cover in that conference, to make sure that the patient and or the family's questions are answered, that their agenda items have been addressed, and to think about how you're going to wrap it up and how you want to conclude that kind of conference, making recommendations to them as appropriate, and then letting them know how they can reach you afterwards or if questions come up after the conversation.
The first step to improving skills and knowledge at the end of life is to place enormous value on this area. This has to be regarded as part of the core curriculum in critical care medicine, and just as important as what we have generally regarded as our bread and butter areas like hemodynamic management, respiratory failure, and so forth. This is part of the heart of what we need to know as critical care physicians.
One of the things that we've been doing in our own institution is we've been using a model of communication training where we use trained actors to portray family members. And doctors and nurses learn skills in how to handle emotions. That's something we find it very difficult to work with. How do we handle emotions in a way that allows the person to express their emotion, to have it be acknowledged, and to use it to help move the conversation forward.
The real secret to optimal end-of-life care is making the transition from trying to make the patient better, help the patient survive an illness, to making the patient better from the standpoint of making their death better and knowing that they won't survive a particular illness.
Optimal end-of-life care, in my mind, has three essential components. One is effective symptom management of the full range of symptoms, physical, psychological, and spiritual. The second is good communication about realistic and appropriate goals of care under the circumstances of the specific prognosis with all of its uncertainties. And the third is concordance of the care plan with the preferences of the patient and the family to the best that we can know them.
I would want us to focus on how we can create systems of support for caregivers. People who provide critical care and care for dying people themselves experience loss and they experience grief. And we have not acknowledged that as a very real dimension of caring well for people who are dying means that we have to care for ourselves as well.
But I think that also there are a lot of ICU clinicians who feel that providing good quality end-of-life care for patients and for families can be very rewarding. It can be a very difficult time, and families can be extremely appreciative of both the good quality care that we provide when patients do well, but also the good quality care that we provide when patients don't do well and when they go on to die.
It seems odd and ironic that someone would thank you when a loved one died. But there are situations when a life can't be saved and when the patient or the family or both come to see that the death is inevitable. And in those situations, if good end-of-life care is provided, the family can be very, very satisfied and very grateful. And this comes back to us as tremendous professional gratification.
The key to good end-of-life care seems to boil down to some very simple actions. We need only begin by being genuine, decent human beings who work honestly with our dying patients. We must also be willing to share our humanity, sincerity, and tenderness with the families of dying patients. This is not a very technological solution, perhaps, but nonetheless a very powerful therapeutic tool. When we ask ourselves, can we do better at end-of-life care? The answer may be much simpler than we ever imagined.